Okay, in our video series of gastroenterology lectures, in this video we are going to talk about Crohn's disease. We are going to discuss the presentation, the causes, the management, the diagnosis of Crohn's disease in detail. In my previous video, I talked about ulcerative colitis. In this video, we are going to discuss Crohn's disease in detail. A 30-year-old man comes to your clinic complaining of abdominal pain associated with diarrhea. The diarrhea and abdominal pain is on and off and is there for the last 3 years. Patient has a long history of abdominal pain associated with diarrhea. Patient tells you that doctor, sometimes this abdominal pain is associated with blood in stools, but most of the time it is non-bloody. I have been going to multiple doctors, but my condition has not improved. Patient also complains of right lower quadrant pain. Patient has history of anal fistula repair 1 year back. Patient had 2 episodes of renal stones that were treated. Now this is a classical presentation of Crohn's disease. What is Crohn's disease? Today we are going to talk about it in detail. Crohn's disease is a chronic transmural inflammatory bowel disease. Transmural means that it involves the whole thickness of the GIT tract, and the whole thickness of GIT tract is inflamed. And it can affect any part of the GIT. It can affect any part from mouth till anus. Any part can be affected in Crohn's disease. Unlike ulcerative colitis, where only the colon and rectum are involved, in Crohn's disease, whole of the GIT can be affected in Crohn's disease. But it most commonly involves the small bowel disease, the small bowel terminal ileum. Therefore, our patient was having right iliac fossa pain because ileum is present in the right lower quadrant, and this Crohn's disease most commonly involves terminal ileum. Now you need to know the important layers of the GIT. Important layers include mucosa, which forms the innermost layer, and outer to that mucosa is submucosa, and outside submucosa is muscularis, which is the muscular layer, and the outermost layer is serosa. Now remember, Crohn's disease involves whole thickness of the GIT. It is a transmural involvement. The whole thickness of the GIT tract is involved, and this inflammation would affect all these layers. In ulcerative colitis, in the other hand, in ulcerative colitis, only mucosa and submucosa are affected, while in Crohn's disease, all these layers are affected. Now, the etiology of Crohn's disease is mostly idiopathic. The cause is not known. But immune dysregulation has been known to cause Crohn's disease, where the immune system gets activated against its own body part, the GIT tract, and the GIT tract is affected because immune system starts attacking the GIT tract and causes inflammation of the gut. Now, the risk factors include genetic predisposition. Some patients are predisposed genetically to conditions like these, conditions like Crohn's disease, like the patients carrying HLA-B27. Now, if you remember, we discussed in our video on ankylosing spondylitis. A young man comes to you with lower back pain, diagnosed with ankylosing spondylitis. It is associated with inflammatory bowel disease. Ankylosing spondylitis is usually associated with Crohn's disease. Ankylosing spondylitis is usually associated with ulcerative colitis. Now, ankylosing spondylitis is mainly an autoimmune condition. So, it means that there is some autoimmune association of the inflammatory bowel disease with ankylosing spondylitis. So, both conditions, there is immune system involvement where the immune system attacks its own body. Smoking is a very important risk factor. Therefore, smoking cessation is a very important part in the management of Crohn's disease. Now, if you remember, in ulcerative colitis, we discussed smoking can be protective. Ulcerative colitis is the only condition where smoking can be protective. But on the other hand, in Crohn's disease, smoking is lethal. Smoking can cause Crohn's disease. It is a known risk factor. Familial, it might even run in families. Now, the pathophysiology. How does this immune dysregulation takes place? Basically, Th17, T helper cell 17 has been known to be affected in Crohn's disease. What happens is that Th17, T helper cell 17 is overactivated, and it results in increased inflammation, and that inflammation affects the GIT tract. Other than that, some mutations of nucleotide oligomerization binding domain NOD2 protein have also been associated with Crohn's disease. Now, you just need to have an idea that this patient of Crohn's disease might be having some autoimmune problem where the immune system might be activated and attacking its own gut. You don't need to memorize these exact genes, but the single thing that you need to remember from this slide is Th17 function. That Th17 function gets overactivated, resulting in inflammation. Now the clinical course. These patients of Crohn's disease would come to you, and these patients would have a long history. Usually these patients will be having history over years where they will be visiting multiple gastroenterologists. These patients will be getting multiple treatments. Many times they will be treated as infectious diarrhea, but these patients would get treated. These patients will again and again will be having these abdominal pain associated with diarrhea, and sometimes that diarrheal episodes will be associated with blood. These patients usually have a chronic intermittent course. Chronic means that these patients will be sick most of the time in the year. And intermittent means that sometimes these patients will have acute flares, acute worsening of the disease. And in between those acute worsening, there will be periods where these patients will be totally normal. These patients will be feeling totally fine, and all of a sudden their condition worsens and they get these acute flares of the disease. And then the condition remits and these patients are totally fine. So there is a chronic intermittent course where there are acute flares and periods of remission where the patient is totally fine. Now, what is the clinical presentation of Crohn's disease? Remember, these patients would come to you with chronic diarrhea, with or without lower GI bleeding. Now remember, GI bleeding is not a classical hallmark of Crohn's disease. According to the textbook, GI bleeding is most commonly seen in patients with ulcerative colitis. While in patients with Crohn's disease, there can be GI bleeding, but most oftenly the GI bleed episodes are less as compared to ulcerative colitis, where there is full bloody diarrhea. In Crohn's disease, the diarrhea will be sometimes associated with lower GI bleeding. Now, this is a classical textbook presentation. In real life, there is a huge overlap between Crohn's disease and ulcerative colitis, and sometimes it gets really tricky and difficult to differentiate because patient might be having both features of ulcerative colitis and Crohn's disease in the real patients. But for the textbooks, you must remember that GI bleeding is not the classical hallmark of Crohn's disease, but it can sometimes be present in the patients. Abdominal pain. These patients will complain of right lower quadrant pain. The right lower quadrant pain occurs due to the involvement of ileum, because as we said, terminal ileum is most commonly involved. Therefore, terminal ileum is present in the right lower quadrant. Now, I'll compare everything with ulcerative colitis so that you can memorize both of these conditions and you can memorize the differences. Where does the pain most commonly occurs in ulcerative colitis? In ulcerative colitis, pain most commonly occurs in the left lower quadrant because it mainly involves the rectum, and rectum and sigmoid colon are present on the left lower quadrant, while Crohn's disease most commonly involves the right lower quadrant. Patient might also complain of abdominal mass present in the right lower quadrant, or you might even examine the patient, and when you examine the patient, you might even feel a mass in the right lower quadrant because the terminal ileum has been inflamed to an extent that you will feel that there is thick mass present in the right lower quadrant. So this is a classical presentation of patient with Crohn's disease. It can involve from mouth till anus. Any part of the GIT is affected, but remember a very important point. The lesions will not be continuous. The lesion will not be starting from mouth and will end at anus. There will be skip lesions. Some of the GIT tract will be totally normal, and at some points there will be lesions that are present. These are called as skip lesions because some of the GIT tract is skipped and then there is a lesion. Some of the GIT tract is skipped, it's totally normal, and then some part is affected. Some part of GIT is totally normal and some part is affected. That is called as a skip lesion. In contrast to ulcerative colitis involves whole of the colon and the rectum, and the lesions are continuous starting from colon ending at anus. These are continuous lesions in ulcerative colitis, while in the Crohn's disease, the lesions are not continuous. The lesions are skip lesions where some parts are affected and some are not. So the clinical course says that it affects whole of the GI tract from mouth till anus. Any part can be affected. It is not limited to colon as it occurs in ulcerative colitis. In ulcerative colitis, only colon is involved. There is continuous involvement. In Crohn's disease, there are skip lesions. Remember, Crohn's disease most commonly affects terminal ileum. Now coming to the clinical course of ulcerative colitis, in the clinical course what will happen is that it will usually starts as an ulcer, a small ulcer in the small intestine, and that small ulcer would further deepen down and it will involve the whole thickness of the gut wall. The whole thickness of the gut wall would be inflamed and there will be transmural inflammation of the intestinal wall. The whole thickness of the wall is affected. Now a very interesting thing happens when one wall is fully inflamed. When one part of the body, when one body wall is inflamed, what happens is it becomes sticky and it starts to stick with the other organs. Now let's say small intestine wall is fully inflamed in Crohn's disease. What it will happen is that it will stick to the wall of gallbladder, and when it sticks to the wall of gallbladder, it will spread the inflammation from small intestine to the gallbladder wall, and the gallbladder wall also starts getting inflamed. Then what will happen is that a small passage will be created. A small passage will be created between the intestinal wall and the gallbladder wall, and the contents of gallbladder will come down to the small intestines directly, and if there are stones in the gallbladder, those stones will travel from gallbladder to the small intestine directly. This is so interesting, that how inflammation is spreading from one organ to another organ and how they are sticking with each other, and passages are formed, fistulas are formed, and those fistulas are connecting different body organs, resulting in the clinical presentations that we see in the patients. These patients most commonly develop anal fistulas. These patients most commonly develop enteric fistula, where one part of intestine attaches with another part of intestine and forms a fistula. They also form fistula between gallbladder and small intestine, resulting in stones traveling from gallbladder into the small intestines and resulting in obstruction. That is called as gallstone ileus. Now these will adhere to other organs or skin, and they will form abscesses, and later on these will form passages, and those passages are called as fistula. This is so interesting. Every clinical presentation makes sense when you know the pathophysiology, when you know how the things are happening, how the disease is progressing. If you don't know the pathophysiology, you will just be cramming down the symptoms. When you cram down the symptoms, you might memorize it for some time, but you won't know what is happening in the body. So it's very important that you remember each and every reason for the clinical presentation, for the clinical symptoms that that patient is having. Now it is very important to remember that sometimes perianal fistulas or abscesses are often the first sign of Crohn's disease. Maybe a patient would come to you and patient is having recurrent fistulas. Patient is having one anal fistula 1 year back, and patient again developed fistula in any other part of the body, but that patient is having recurrent episodes of fistulas. It means this should hint that there is some kind of inflammation going on in the gut walls, and that inflammation is resulting in presentation of fistulas again and again in that person. Perianal fistulas and abscesses can often be the first sign of presentation. Now, it usually starts as an ulcer. Look at the ulcer that is present over here, and this ulcer will further deepen down and cause the involvement of the whole bowel wall thickness. Then this intestine forms a small passage, the fistula, and this fistula comes out on the skin. Now it has involved the abdominal muscles. It has involved the whole thickness of the abdominal wall. The inflammation started spreading as an ulcer, and that ulcer has further deepened down, involved the intestine, and that intestine has involved the fats, that intestine has involved the muscle, that has also involved the skin, and that appears as a draining fistula on the abdomen. This is an enteric fistula, where one intestine gets attached to another intestine through a passage, through a fistula. Now coming to extraintestinal manifestations, remember inflammatory bowel diseases like ulcerative colitis, Crohn's disease are usually associated with extraintestinal manifestations, where they involve the joints, because they are associated in patients with HLA-B27, and HLA-B27 are the patients who also have ankylosing spondylitis. So it involves the joints and it causes enteropathic arthritis. It can usually involve the eyes, resulting in uveitis. And uveitis is inflammation of the choroid, iris and the ciliary body and presents as photophobia and redness in the eye. In the gallbladder, you will see stones, you will see cholelithiasis. Now, how does cholelithiasis occur in patient with Crohn's disease? There is a reason. Whenever there is Crohn's disease, there is diarrhea, and whenever there is diarrhea, there is loss of bile acids. There is loss of bile acids being secreted from the gallbladder. Normally, gallbladder secretes bile acid. Those bile acids emulsify the fats, and then they are reabsorbed back through the ileum, through the small intestine. But ileum is inflamed in Crohn's disease. When the ileum is inflamed in the Crohn's disease, those bile acids cannot be taken back, cannot be recycled back to the gallbladder. Therefore, there is deficiency of bile acids in the gallbladder. When there is deficiency of bile acids in the gallbladder, the fats cannot be emulsified, the cholesterol cannot be emulsified. Therefore, the cholesterol and the fats precipitate in the gallbladder. When they precipitate in the gallbladder, they form stones. Therefore, you see cholelithiasis. Therefore, I talked about gallstone ileus, where the gallbladder wall gets attached to the small intestine and results in fistula, and those stones travel down the intestine and block the intestines. Now, these patients of Crohn's disease can also have renal stones, as our case in the initial presentation had 2 episodes of renal stones. Why do renal stones occur? These also occur due to diarrhea. Now remember, normally whatever we take, oxalate we take in our food, like in the green leafy vegetables or in the tea or chai that we take, that has oxalates in it. Calcium in our gut, in the GIT tract, in the stool, bind this oxalate, and that oxalate is excreted in the form of calcium oxalate in the large intestines, in the stools. Now, whenever a patient is having Crohn's disease, this patient will be having fat malabsorption. Whenever there is fat malabsorption, fats will bind the calcium and will cause saponification and will get excreted in the stools. Now, the oxalate had to bind with calcium to get excreted in the stools, but the calcium is now binding to the fats. Therefore, the oxalate is free, and that oxalate will get absorbed in the blood, and then from the blood it is excreted in the kidneys, and in the kidneys it binds to the calcium. But when it binds to calcium in the kidneys, it forms stones in the kidneys. Therefore, these patients will be having calcium oxalate stone, renal stones in the kidneys. These patients will be having erythema nodosum, pyoderma gangrenosum, very important association, especially the pyoderma gangrenosum. It's a bit different and you won't be able to see it anywhere else, and it will commonly be in the questions, especially on step 1, where you would see pyoderma gangrenosum picture given like this, and they will give talk to you that this patient is diagnosed with pyoderma gangrenosum. What is the most common association? Crohn's disease is the most common association of pyoderma gangrenosum. Now coming to the classification of Crohn's disease. Remember, classification of Crohn's disease is not very important for you to memorize, but it is just added to the slide to give you an idea that how Crohn's disease is classified. It's basically classified based on the symptoms. Number of liquid or soft stools each day that patient has passed for 7 days. If the patient has passed it 2 stools in the last 2 days, you multiply it by 2 because that has crossed 2 weightage factor. If the patient has abdominal pain, you grade it from 0 to 3, and then you multiply that grading with 5. If the patient grades it as 3, you multiply 3 by 5 and add 15. General well-being, subjectively assessed, patient feels well, that is 0, patient feels terrible, that is 4, each day for the 7 days, and whatever score patient tells you, you multiply that with 7 and you add up all these values that you are calculating. If the patient is having complications like anal fistula, that has a huge weightage, and that will get a score of 20 because, as I said, sometimes fistula can be the only presentation of the Crohn's disease. Use of diphenoxylate or opiates for diarrhea has a huge weightage, and the more opiate the patient is needing to stop the diarrhea, it indicates the more severity of the condition. Remember, clinically you can assess a patient. If the patient is demanding more and more loperamide or Imodium to stop the diarrhea, it means that patient is having severe diarrhea and that patient is having severe status of Crohn's disease. It has huge weightage factor of 30. If the patient is using, you multiply that with 30. Abdominal pain, abdominal mass, absolute deviation of hematocrit, percentage deviation from the standard weight. Now you multiply all these values, you add up all these values that you are getting, and if they are less than 150, the patient is in the remission phase. If they are greater than 450, the patient has severe disease. If they are in between, then they can be mild to moderate or moderate disease. Now this is just to give you an idea how it is classified. You don't need to remember these for your exams. It is just for the clinical practice. Now coming to the diagnosis of Crohn's disease. In the diagnosis of Crohn's disease, it's very important that you take a proper history from the patient. You do physical exam, and at the very important point that you have to do is that you have to perform digital rectal exam in these patients. DRE is very important in these patients to look for rectal involvement. Normally in the patients of ulcerative colitis, when you perform the digital rectal exam, your finger will be filled with blood, because those patients will have full involvement of the last parts of the GIT in ulcerative colitis, while in Crohn's disease it might not be the case, because rectum is usually spared in Crohn's disease. After that, the main thing, the most important thing is endoscopy. You go for ileocolonoscopy, you go for endoscopies, you look at the GI tract. Till the time you have not seen these ulcers, till the time you have not seen the inflammation with your own eyes, you cannot trust the symptoms only. So the findings that you will see is the skip lesion. Some part of the GIT will be having lesions, some parts of the GIT will be totally normal, and then again you will be seeing the lesions. Another thing that you will see in the patients with severe Crohn's disease is cobblestone sign. What is cobblestone? Cobblestone is the stone pattern like this in the past, where these stones were placed on the roads to make the roads. So that pattern is commonly seen in patients with Crohn's disease due to chronic state of inflammation that is going on, and that fibrosis that gives it an appearance like cobblestone. Now, when you have taken the history and physical examination, usually endoscopy in 80% of the cases would give you the diagnosis. Now, it's very important that if the patient is having presenting to you with any fistula, or you are suspecting that the patient has now progressed to the formation of fistulas, it's very important that you want to find out where these fistulas are present, and for that, to look for the complications, that where these abscesses and fistulas are present, it's very important that you perform cross-sectional imaging. In the cross-sectional imaging, you perform MR enterography, CT enterography. These are special types of imaging that is specific for these guts, and these enterographs, they give the contrast and they see the spread, that where that contrast is spreading towards, and they will help you to find the presence of fistula. So cross-sectional enterography should be performed even if you have a slightest hint that that patient might be having a complication of Crohn's disease. Diagnosis is made by ileocolonoscopy and biopsy. Small bowel follow-through studies, where the contrast is given and that contrast is seen, how the contrast is passing through. What you will see that there will be string sign. The string sign is that at one part of the GIT, most commonly terminal ileum, the contrast will get very thin. The contrast will be thinned out because the GIT, the wall is inflamed, and there is fibrosis and thickening, and there will be some kind of obstruction, stricture formation in the GIT. That obstruction due to chronic inflammation would appear as a string sign, because the dye is very difficultly passing through this passage. These Crohn's disease might even present to you with obstruction, because this type of inflammation can also form strictures where the small intestine can get blocked. Now remember another important point, that a certain type of antibody can be positive in patients with Crohn's disease, and that antibody indicates immune system involvement, and that is anti-Saccharomyces cerevisiae antibody. In clinical practice, that is quite low yield, but in patients, in exams it is very high yield. They might give you a question and they might give you a hint that that patient is having anti-Saccharomyces cerevisiae antibody positive, ESCA positive, and you would be confused at what is this name. This is basically a name of a yeast, where they see the antibodies against that specific yeast, but those antibodies are also present in patients with Crohn's disease and patients with inflammatory bowel disease. Now, do you remember which type of antibody is positive in ulcerative colitis? In ulcerative colitis, P-ANCA is positive. So it is a very high yield point for exams, where they will ask you for P-ANCA positivity in ulcerative colitis and ESCA positivity in Crohn's disease. When you perform the endoscopy, when you pass down the scopes, what you do is that you also take biopsies. Remember, It is very high yield to know that Crohn's disease has non-caseating granulomas in it. Crohn's disease will have granulomas that are non-caseous. Do you remember any other condition? Can you name another condition where there are non-caseous granulomas? You can comment in the comment section below. In tuberculosis, you see caseous granulomas, but in Crohn's disease, you see non-caseating granulomas. These granulomas are not seen in patients with ulcerative colitis. So, if they give you a case of inflammatory bowel disease and in between the lines they tell you that that patient is also having non-caseating granuloma in the biopsy, they are technically telling you choose for Crohn's disease option. Now, this is a very beautiful picture showing creeping fat appearance in patients with Crohn's disease. Normally, intestines are like this, where the fat is not getting super excited and fat is not creeping over the small intestine. While in Crohn's disease, the fat creeps over and starts spreading around. Why is fat attaching to the small intestine? It makes sense now, because the small intestine wall is inflamed and it is attaching everything that is coming near to it. So the fat will also stick to the inflamed wall and the fats will be creeping over the walls of intestine. See the fissure present here, see the cobblestone mucosa, the fat wrapping around, the thickening of the wall, so that can result in the obstruction and the string sign that you see on the radiography. So it is very interesting when you understand the pathophysiology. Everything makes sense when you understand how the things are happening. In the next video, we'll be talking about the management of Crohn's disease in detail. So do not miss out that video, and please make sure to check out my other videos on gastroenterology lectures, emergency medicine lectures, neurology lectures, and do support this channel on Instagram as well. Thank you very much. In summary, we talked about the case that we had, what is Crohn's disease, the involvement of the transmural involvement, the etiology and the risk factors, the pathophysiology, clinical course, that is chronic intermittent, the clinical presentation with diarrhea, abdominal pain, abdominal mass, the skip lesions commonly involves the terminal ileum, how fistulas are formed, the important points, how ulcers can spread to fistulas, and the extraintestinal manifestations of Crohn's disease. Pyoderma gangrenosum, the classification, the diagnosis, the DRE and ileocolonoscopy, the most important one. Then the cobblestone mucosa, cross-sectional imaging to identify fistulas, MRE, CTE, small bowel follow-through showing string sign, and the antibodies that are positive, non-caseating granulomas, creeping fat appearance. If you liked my video, please click on the subscribe button and make sure to check out my next video on the management of Crohn's disease. Thank you very much.